Postop's approach for complex valve repair hand technique. Please start your lecture.
Dear colleagues and friends, this approach, we have been talking about it a lot. I just want to introduce our technique, and I would like to discuss with you whether you can do some more complex repairs with minimal invasive access too. I personally think, although it was criticized yesterday, that the mixed approach is the gold standard in mitral valve reconstruction for mitral and for tricuspid procedures. Here's an example of how we proceed. We cannulate the groin vessels by puncture, as we do it in the TAVR business too. We close those vessels afterwards with ProGlide, and we do all those operations in one of the hybrid rooms we have, so we can have radiation and see what we are doing while advancing the cannulas. This is the ProGlide system. We use 2 of those ProGlide systems for each vessel. Insert the wire again, put the second ProGlide system. You can use those systems for the vein and the artery, although it is off-label use, but because the cannulas are too big, but it works very well actually. Ever since we have started to do this, we have much less groin problems in terms of limb fistula or pain or infection in the groin. And then we do the incision. We do it always the same. From the mid-sternum, we go to the right thorax, do a 4 or 5 centimeter incision. We use a soft tissue retractor. This is the 3D Storz camera that is inserted. We do direct clamping of the aorta and normal cardioplegia, as you see here. The interatrial groove is prepared, the aorta is clamped, and the atrium is opened, the atrial lifter is inserted, and you have a pretty good view with the 3D camera. This is a typical case of P2 prolapse, as you see, with flay leaflets. We always place the ring sutures first. Since we have been using the 3D camera, we start on the posterior part of the valve, on the posterior commissure, so that the sutures are not in the way of the camera. And then we do the valve testing. We measure the surface of the anterior leaflet. The ring suture, the Gore-Tex sutures are placed in the papillary muscle. In this case, we do not do a resection, although of course it can be discussed. But in the last years, it has evolved more and more to do less resection and even more chordate than before. And then we insert the neocords into the posterior leaflet. We go a little bit higher than the edge of the leaflet to have a better coaptation and to pull it all the way down into the ventricle. And then we adjust the height by injecting saline. See, it's too far in. We'll pull it out a little bit. There are many ways to determine the length of the chordae. We get the best results with the water test. We clip the chordae and the clips are removed later on. And then we are done with the procedure. The aorta is unclamped. Left atrium is closed. The vessels are closed with the ProGlide systems. And the thorax is closed. This is now pretty much the standard procedure we perform. Now I was asked to show some examples of whether you can also repair some more complex than just a P2 prolapse. We performed a comparative study between mixed access and sternotomy a couple of years ago and published it, and we saw that the patients are pretty much different, but if you do if you match those patients, then you have the same risk factors, and here you also see that a lot of parameters like cross-clamp time, bypass time, hours on ventilator, and so on are different if you do not match. But if you match the patients, then the only difference that remains is cross-clamp time and bypass time, which is a little bit longer in the mixed patients than in the median sternotomy. And if you look at long-term survival, there's no difference between minimal invasive and median sternotomy, and also freedom from valve-related reoperation is not different. Complications are very low. Mortality is below 1% in almost all big centers who do this kind of procedures. Now, if you look at the literature, you can see that sternotomy approach has a little bit shorter cross-clamp time and bypass time, but then for mix you have less blood transfusion, less ventilation time, shorter hospital stay at ICU. You have less groin complications in sternotomy. However, if you do a puncture, then the groin complications go down, and the operative mortality and survival and freedom from reoperation are the same. And so Michael Mack once said, if a technique is equal in quality and less invasive than another, it is by definition better. So the question is, can you do some more complex procedures with the mixed approach? And you see here from the David Adams group that a lot of patients are more complex than just a P2 segment prolapse. And so let's look at some cases. One of the problems, I have to admit, with a mixed procedure is the tricuspid valve. It can be a real hassle to reconstruct the tricuspid valve through this approach. Now here's the mitral valve. In this case, we did a little resection, reconstructed the posterior leaflet, and what I really wanted to show is you snare the superior and inferior vena cava, and then you open the right atrium. So far, so good, but in some cases, the tricuspid valve is really difficult to reach, and so in most cases, you have to put your ring sutures first to expose the tricuspid valve. This is one of the reasons why some physicians do not do the tricuspid valve in mixed procedures, which of course is a pity, because it should be done, especially in severe ring dilatation. So it can be done, but it's not easy. This is another case with endocarditis, also a mixed procedure. Same approach. Here you see the vegetation, resection of the vegetation. We always put the ring sutures first, then resect. Put Gore-Tex sutures. In this case, we put in a glutaldehyde fixed pericardial patch to replace the P2 segment, and then put Gore-Tex sutures to the pericardial patch. As you see here. So this can also be done through a minimal invasive procedure. This is another case I'd like to show you. Severe prolapse, a lot of tissue, very big P2 segment. In this case, we did a resection and reconstructed the posterior leaflet. Here another case, also a lot of tissue, flay leaflet at P2. Put the ring first, and then we put sutures on the posterior leaflet, and then we saw that the anterior leaflet was prolapsing more than we thought, and did a small resection. And as you all know, with those resections you have to be really careful, and they have to be very small. Also, we did a commissural stitch for commissural prolapse. Here we closed the gap. Some surgeons close the gaps always, like Patrick told us yesterday. I close them only if I have to. Another case. Again, severe prolapse on the P2 and P3 area. We use this sizer usually to expose the papillary muscles. In this case, we did application on the posterior leaflet and then put the Gore-Tex sutures. And again, a commissural stitch. This is also an endocarditis. Of course, in endocarditis, you have to be absolutely sure that you have no vegetations on the aortic or the tricuspid valve. Tricuspid you can treat, of course, but I wouldn't do it through a minimal access. In this case, we could close the hole in the anterior leaflet and put a ring. And this is the last case I wanted to show you with a functional MR, as you see here. In this case, we did an augmentation. We have been doing a lot of patch augmentation before, and now we started to do the papillary muscle augmentation. In this case, we use a Teflon felt on the papillary muscle and put the sutures through the ring and later through the prosthetic ring. We'll put two of those sutures. There was also some prolapse of the anterior, but you see that the valve is not competent yet. And then here you see how you can lift the sutures and how the posterior rim comes up, and then the valve is absolutely competent. So I end here, and I just wanted to show you a couple of cases and demonstrate that even through a mixed access, you can apply quite a lot of different techniques to the mitral valve. Thank you.
Thank you. Are there any question or comment from the audience? Please.
Yeah, one short question, Rudiger. About the, I mean, I like really to have your opinion. I see more and more calcified cortex coming back. Do you have this experience? And ruptured?
No, not calcified. They are stiff, fibrosed, but really calcified.
Calcified and really ruptured, like broken, like what I call the dry spaghetti syndrome. Became really very stiff and broken. And we have about more or less 10 cases now of calcified and ruptured cortex 7, 8, 10 years after the surgery.
This is an observation I can share with you, and I always ask myself, why do they break in the middle between the papillary muscle and the leaflet, right in the middle of this? They do not break at the leaflet and not at the papillary muscle, right in the middle. I have no answer to this.
Yeah. For why I'm, contrary to you, I'm less and less using cortex if I can resect. So because I am really worried about this. That's only,
Okay.
meant to do, yeah.
Any other comments?
Yeah, could I ask a question from up here? Essentially, it sounds as though you don't believe that excessive tissue, at least in the posterior leaflet, is an issue as such, as long as you keep the posterior leaflet pulled well down into the ventricle, so it's not going to produce a systolic anterior movement. Is that correct?
This is correct. I had a big discussion about this at the last AATS in 2019, because the American surgeons all debate that you have to resect diseased tissue. I personally do not think you have to resect it, and our long-term results are very good, unless the tissue is calcified. I mean, in calcified tissue, I would always resect. But if it's not calcified, it's just fibrosed, I just pull it down in the ventricle.
So if you had in the anterior leaflet a billowing, elongated, spinnaker-like segment, say in A2 or A3, for example, how would you deal with that? Would you still just use the cords on it, or would you resect that?
It's a bit difficult without the two of us seeing the pathology, but primarily I would use cortex, and only resect in very few cases.
Yeah. Okay.
I ask you one small question. And you said you left the cleft, if possible, or you don't want to close the cleft. Gaps, never. No, because yesterday Perry says, yeah.
And one of my colleagues, who's a very good mitral surgeon, he always closes the gap even before he tests the valve. And I think Patrick does the same. I never do it, only do it if the valve is leaking through the gap. Otherwise, I wouldn't do it. Why? Because it makes the posterior leaflet stiffer. We have as a surgeon, you have a functional approach to the valve. So if it's not leaking at this at the gap, why should I close it?
You don't want to close the cleft because of you don't want to make stenosis, right? Yeah. Okay. Thank you. Other questions? No. Okay. Next speaker is Gardner. I don't have a guideline. I'm sorry. How to do complex MOV repair by Gardner? Please start your lecture.
I have to give you somewhat of an apology because I was only aware that I had to speak on this a short while ago, so I haven't got a formal presentation. I did have an older presentation here on recurrent MR, and we've got some technical problems here with it. So, not sure what's happening. I don't profess to be an expert on reoperating on complex mitral valves, but my personal experience started around about 1990, and between 1992 and 2011 we kept a database retrospectively for a while and then prospectively, and as a single surgeon database, and there were 605 mitral valve procedures performed by me over that period of time. How are you going? So I was an experienced surgeon at that stage, but I certainly wasn't experienced in mitral valve surgery. So this experience for me incorporated very significant learning curve throughout. So we did have a number of early failures. Now, we got that? Good. Okay. So we're not moving through that. What are we doing here? Not showing? Okay. So what the initial techniques that I used were essentially those of Carpentier, which was a resection, quadrantic resection of the posterior leaflet, and a local annuloplasty, if you like, on the valve. And most of the patients had a ring put in, initially a pericardial ring, and thereafter either a Cosgrove band or a physio ring, and the predominant annuloplasty device was a physio ring. The anterior leaflet was dealt with by artificial chordae. The intention at that time, even relatively experienced, was to set out to try and repair all degenerative mitral valves. And that improved over time. But when I reviewed all our work in recent years with a follow-up of 20 years up to 2016, found that 90% of patients that came to the operating theatre with degenerative mitral valve disease had a mitral valve repair. I always thought it was important to, when people present their work on mitral valve repair, that it always needs to be put in perspective about what percentage of patients they see with degenerative mitral disease that are actually being repaired. So as I said, there were a number of early failures, and what I came to appreciate after a long time was that there was an interplay between progressive mitral disease, technical aspects of the repair, and the remodelling processes that occurred after you actually repaired a valve. What was the interplay between these in terms of producing a recurrence? The most significant factor that, how are we going? Not too good. Most significant factor we found after had quite a number of covariates was that the main predictor of reoperation or relapse, significant recurrence, that's MR greater than 2+, after the operation, was the degree of MR on the post-pump transesophageal echo, and that was the strongest predictor. So that if you had 0 to a trace, MR was significantly different from 1+, and I suppose in the early days we accepted some patients who had more than 1+, but the reoperation and relapse rate was significantly higher in them. And the techniques that I used in those days was essentially resectional techniques, apart from cords in the anterior leaflet. But say with a Barlow's type valve, there'd be a fairly radical resection of what was considered to be excessive tissue. So we do quadratic resection, leaflet reduction and slide on the posterior leaflet, and sometimes quite large quadratic resections, local annuloplasty. And it became evident that with the relapses and recurrences that we saw, that there were significant issues if these procedures weren't done to the appropriate pathology. So when we analysed our posterior leaflet repairs subsequently, we found that if you did a slide and a quadratic resection, the recurrence of MR or relapse was higher, significantly higher. And the reason, I think, was because we didn't really understand the remodelling changes that occurred in the valve. And this is one of the disadvantages, I reckon, of resection. Because if you resect any leaflet tissue, you end up with scar. You'll end up with some calcification along the suture line potentially, eventually. You will also, if you don't have sufficient tissue in the posterior leaflet, because what happens is that the posterior leaflet will contract, you'll get pannus along the edge of the annulus of the ring, and you'll get shortening of the posterior leaflet. And this is why some patients that have these procedures get a very good initial result, and then 8-9 years later they've got recurrent MR, and when you reoperate on them, the posterior leaflet is shrunken. So with the work of Patrick Perrier and the importance of respect over resection, it reinforced the importance of making sure that one had adequate tissue in the posterior leaflet, the completion of the repair, most important. And this is where the non-resection techniques, where you've got that a lot of tissue there, should predictably give you a long-term result. I've not had any patients that I was recognised had ruptured chordae. We always used 4-0 Gore-Tex. I don't know whether you used 5-0 or 4-0. Didn't use 5-0. I've certainly had some Gore-Tex pull out. But when we reviewed the main reasons for failure were, number one, the amount of MR on the post-pump toe. But then as time passed, when patients came to reoperation, it's often said that, well, if you get early failures, it's a technical issue. Long-term failure is progressive disease. And that came out in David's paper as well, for his long-term follow-up, because he looked at the amount of disease in the valves, and if there was more myxomatous disease, there was more evidence of recurrence. I don't think we found that. What we found in analysing the reoperation rate, and the incidence of reoperation was 10% at 20 years on an actuarial basis, but there were, I think, about 37 reoperations, and I think there was 5 or 6 of those that actually came from elsewhere. But what we found on when we looked at the pathology, when I looked at the pathology, was that most of it came back to endocarditis excluded, of which we had a couple of those on the ring and one on the valve. All the others, you could really implicate the technique of repair. And so we came to the conclusion, looking at this, that progressive disease was probably not a significant factor in the long-term results, because, again, when we looked at the echoes that were done between 1 and 3 years post-operatively, if you had no MR, if you had a competent valve on an echo between 1 and 3 years after the operation, your long-term result was excellent. The incidence of recurrent MR and reoperation was extremely low. If you had more than 1+ MR, then at that early stage, then the results weren't nearly so good. So the reoperation and recurrent MR without reoperation incidence was significantly higher. So I felt that reinforced the fact that if you've got a good initial repair, and if that repair was durable, at least in this early stage, and holding up in this early stage, that you would get a very good long-term result. So getting back to the subject that I was supposed to talk about in dealing with re-repairs, when initially my experience was that, and most people accepted at that early stage at least, that if you re-operated on someone after a mitral valve repair, you automatically replaced the valve. And came to think that, well, that wasn't so, and then there was some work, I think from DuPont and Zegdi, that showed that if you did a repeat repair on the valve, you could get a very good long-term durable result. So the attitude changed so that I would attempt to re-repair the valves in those cases. And I think there are a number of factors which were important in making that decision or determination. And one was the amount of tissue that was left in the valve, the quality of the tissue that was in the valve, and of course if there's calcification present or not. And I think that the other decision point is when we all talk about 100% repair in every 100% repairs for degenerative mitral valve disease. No one does 100% repair for mitral valve disease, for mitral valve degenerative, because what do you do with those big calcific bars? What do you do with the patients with a lot of calcium in the leaflets? Some of those get replaced. So we probably can never get to 100%, but we can get pretty close to it. So the approach was to attempt to re-repair these valves, taking into consideration that, and also the fact that, I mean, if you go into re-repair a mitral valve and you've got to do 2 coronary bypasses and aortic valve replacement at the same time, then and it's quite a complex procedure to try and repeat the repair, obviously you're going to probably resort to do a valve replacement in that situation. The only techniques that I could really tell you about in terms of repeat repairing were that the approach was to try and rebuild the valve, and so that if there was deficient tissue particularly in the posterior leaflet, we'd augment that with glutaraldehyde fixed pericardium. The anterior leaflet as such, I have enlarged as well with pericardium to enhance it, and the use of Corday, depending on the reason for the recurrence. And the other things, I suppose, that you're confronted with are other technical issues where you get breakdown of the repair, particularly if you do resections, and you're more likely to get breakdown. You can have dehisced rings in a small number of patients. You can get endocarditis on the ring. And I don't know how you all feel you should deal with someone with endocarditis on a mitral valve that's had a previous repair. My approach for those that had endocarditis on the ring was to take the ring out and fashion a pericardial strip, usually a bovine pericardium at this stage, rather than, although you could use autologous, fashion a pericardial strip and place that around and use that as an annuloplasty type of device, and put it across the gutter where the initial ring had come out, and use 5-O-proline to sew it in around the edges. Now, that was an innovation. I can't tell you that that's a particularly good procedure or not, but it did seem to work, and we didn't have to reoperate on those couple of patients that had that. So I think the approach essentially is, if the situation exists where you feel that it's reasonable to attempt to repair a complex mitral valve, all the factors are in your favour to do that, and you have time, and there's no other comorbidities or other procedures you need to do to spend some time on it, then I think it's certainly worthwhile trying to rebuild the valve. And the patients that I've done that on, which have only been a small number, have generally done quite well. Where it's failed was one patient that had a lot of restriction, and that valve had to be replaced. A lot of caudal restriction on both leaflets, that had to be replaced. Another patient who had a Durand ring put. This patient had a big calcific bar. She had mitral regurgitation, posterior leaflet prolapse. The surgeon that operated on her put a Durand ring inside the left atrium to try and pull the left atrium over the valve, which of course didn't work. And she came back with a dilating ventricle. And I made the mistake with this patient. She had a very small anterior leaflet. She had posterior leaflet prolapse. We did do an en-bloc resection on the calcium, and at the end of the operation, the anterior leaflet was small, the posterior leaflet was standing up a bit, the valve was competent, but the coapsion line was short, and I made the mistake of leaving it. Well, within several days, she had a 2-on-4 MR, and the posterior leaflet looked as though it was prolapsing. So a week after initial operation, we took her back to theatre and re-repaired the valve by putting a substantial patch in the anterior leaflet and a cord in the posterior leaflet, and we had a good length of coaptation and a competent valve. So to sum it up, really an ad hoc presentation, I apologise, but I think that the approach should be for a reoperation on a mitral valve to look at the factors, look at the tissue you've got, look at the causes, and if possible, re-repair it, because I think that you can get a good long-term result by doing that. And I just wonder, I was going to ask Dr. Lange that if you do a reoperation for recurrent MR, is there a place for minimally invasive surgery in those patients, or would you do them through a median stenotomy? Thank you.
Thank you very much.
I'm really sorry about that. That's just some technical issue here. Yeah.
To answer your question, we don't do reoperation through a minimal access, but it can be done apparently if you use the endoclamp. But then still you may face severe adhesions between the lungs and the atrium, and it's certainly not an easy operation. I'm not sure whether it's worthwhile to do it, but I have never done it. The other comment I would like to make is you said in a case with endocarditis you would take out the ring and then replace it by a pericardial strip. Now, I personally, I agree that you should always take the ring out, regardless of whether you have endocarditis or not, so that you have the valve in its former native or almost native state again, and then try it again, look at it again, and then you can put a new ring in, and even in endocarditis, we always put a new ring in. I don't see any reason to change to pericardium, actually. But to take the ring out, to re-evaluate the valve, I think is important. There are very, very few incidences where it's so obvious that you just put one Gore-Tex or just one stitch and the valve is competent again and can leave the ring in. But in most cases, I would always recommend to take it out.
I had two patients that had repair. Both were posterior leaflet repairs, and a resection and the approximation of the posterior leaflet was done using proline. And both of these patients presented with recurrent MR, and they both had erosion of the free edge of the A2. And to the point where I re-repaired one, and it recurred quickly, so he had to have a third operation and replacement. The second patient I had, I re-repaired. I put a different ring in. We put some cords in the anterior leaflet in the midsection where it had been eaten away and lost the free edge cord, and put a smaller ring in. And that patient did well and has not got recurrent MR after a long period of time now. So I don't know if other people have experienced that, but certainly having seen them, I made sure that I changed from Proline to a 5.0 Ticron with a soft, and then not long after that made sure that all the knots on the posterior leaflet were on the left ventricular side. So there was no rough edges or sharp bits, particularly with 4.0 Proline, where you could get this problem with erosion. So it's something that very few people have ever, other than myself, have ever seen, I think. So I don't know whether anyone here has had that experience.
Okay, any question or comment? No? Our time is limited. Thank you very much.
The next speaker is Dr. Okita, bicuspid aortic valve repair, a success-proven approach.
So there are many congenital abnormal aortic valves. So I'm going to talk about the bicuspid aortic valve. So as you know, there's a surgery for congenital abnormal aortic valve consists of two techniques: repair with the aortic valve and replacement or repair with the aorta. And this is a contemporary clinical outcome of aortic valve disease studies. And if you see the red letters, aortic surgery is not so prevailing, not so common. Actually, the aortic dissection is very few, one or at most 10% after 20 years. So this is a normal anatomy of aortic cusp done by Brussels groups, but this is tricuspid. In the bicuspid, it is not applicable to the bicuspid aortic valve. So. And the size of the cusp itself is much different from tricuspid valve. And this is a famous classification by Dr. Shivers, type 0, type 1, and type 2 is a unicusp. And so type 1 is the most popular ones. So there are many variations between in the bicuspid aortic valve group. So this is a Shivers type 1, and right and non fusion, right and left fusions. And this is a Shivers type 0, 180 degrees. And as for the orthopathy, usually ST junction is smaller than the Bouyer junction. So this is a characteristic of the aorta of the bicuspid valves. And the bicuspid valve have some complications, aortic stenosis and aortic regurgitations. So this is a result of a repair of aortic cusp. Dr. El Khoury over there, and Dr. Schaefer's, and Hatzer-Schaaf, and the course groups. And the clinical result is excellent in all series. And in the Homburg experience, bicuspid and the tricuspid has no differences in terms of freedom from reoperations. And they analyzed the orientation of the cusp is clinical result is better if we have over 100 degrees. And this is similar result from the Brussels groups. And if you have a post-operative pressure gradient over 20, the clinical result is worse. And as for orthopathy, this is the classification from Stanford, and most prevalent one is type 4. That means ascending aorta on the arch. And when you should operate in these patients, it's around 5 centimeter in the guidelines. So my experience is a 370 consecutive aortic root replacement. There was a 68 bicuspid aortic valve disease. And cusp repair in bicuspid valve is all is necessary. The majority have central applications at the Arantius, and some have free margin reinforcement. And compared to the tricuspid and bicuspid valve, application should be 100%, and the clinical result is similar in both groups. And as for the Commissure orientations, native orientation and 180 degrees orientations, we found that although there's no significant differences, but the effective orifice area and the pressure gradient is better in the 180 degrees. And the freedom from moderate AR is similar in two groups. So this is a case, 20 years old male, AR severe and right coronary prolapse, and VA junction is 32, and Barsalva is 44, and the stage junction is 32. This is a preoperative echoes. And the operation was done in a root replacement, and the Commissure orientation is 180s, and both cuspes are plicated. The patient head is on your left. As you can see, the ST junction is very narrow. And we, as for the similar to the tricusp valve, we dig in the aortic root very deeply. And then first we put the Commissure stitches. And non-cusp is dissected. And this is the measurement. We junction 32, and the brussel height was 30. Brussel height means the nadir of the non-coronary cusp to Commissure height. And the sinus is 44, and the ST junction is 32. And graft sizing, there are many ways to measure the graft sizing. We use the brussel groups. And Jabrin told us to not to put the sizer in the bicuspid valve. It's dangerous, right? And we measure the height of the geometric height. Is a non-coronary cusp is the standard reference. And this is a measurement of a brussel height. We did, okay, this is a measurement of effective height. So this is the first source stitch. It's similar, very similar to the tricuspid aortic cusps. We always put 12 3-0 mattress sutures in the horizontal planes, and this is a schematic diagrams. Now we use 30 millimeters of Valsalva graft, and a little bit higher in the between at the membrane septums. And we put the commissure degrees 180 degrees. This is the posterior commissures. And this is anterior, 180 degrees at the level of ST junction with the graft. And this is the second row sutures. And there are some modifications of Dr. Grayson from Pittsburgh and Dr. Svensson in Cleveland. And, they put a patch or inside the commissures. And generally, the cusp is very thick in a bicuspid valve. So I try to shave the valve as much as possible. Initially, I cut the raphe to release the fuse the cusp. And there's some calcification or thickening of cusp itself. I try to shave as much as possible. Sometimes you can get the rock of calciums. So this is the shaving, and you have 100% necessary to close the raphes. And this is the cusp plications. First, we placate the non-coronary cusps. I mean a non-fused cusps to get effective height over 1 centimeters by placating non-coronary the around tear spot. And sometimes we need close the fenestration with the Aortic sutures from outside using a CV7, the raw running mattress. I skip this one. And we use a pressure testing. And this is the post-operative. Of course, we attach the coronaries. Okay, that is my presentations.
Thank you very much. Excellent talk. Are there questions from the forum?
Here we go.
No, I do the same technique. I have only one question or comment on the use of Gore-Tex. I stopped using the reinforcement of the free margin with Gore-Tex because, again, a lot of calcification is induced by the Gore-Tex.
Really?
So now I was so aggressive with the fenestrations on the aortic side. Now, if the fenestrations has something to do with the regurgitation, I try to close and mainly with the small pericardial piece, and I really stop nearly all patients having free margin, but it's not the same technique. It's over and over of the free margin, and use a huge calcification. The Gore-Tex itself, it is not calcified, but you have a really block of calcium on the leaflet.
Is that CV7, CV6?
Seven.
But Tyrone never told us, so.
Yeah, I'm not sure if he's following very well those patients sometimes. I don't know, because believe me that the calcification induced by Gore-Tex on the aortic, on bicuspid, on tricuspid valve, no calcium. But on bicuspid valve, I think that's a question of stress on the free margin. We have a lot of stress on the free margin, on the bicuspid valve, and not on the tricuspid.
Right.
I think, at least in my experience, I really stopped using Gore-Tex to
Leave the fenestration open, right?
leave the fenestrations open, unless they have something to do with the regurgitation itself. So we close with some piece of pericardium, but never now anymore.
But you are trying not to use the pericardium. So.
No, I mean small piece on the if you want. Right. That's the it is really, if you have the echo, you can see that the echocardiographer can tell you we have a leakage. The regurgitation is only at the commissure area sometimes, plus central. And if you find some fenestrations, I try to close. If not, I will not touch the fenestrations.
Right. Thank you.
There are no further questions. Everything is clear. Thank you so much.
Thank you.
Next one is papillary muscle tugging approximation for functional mitral regurgitation. It's my new technique for treating a functional mitral regurgitation. Oh. I suppose that there are so many Thailand people, but this person that, is a member of soccer team in Hokkaido. Thank you very much for Thailand. Background of background. There are so many backgrounds. Prognosis of functional matter regurgitation with medical treatment for ischemic cardiomyopathy and non-ischemic cardiomyopathy is poor, as you know. For example, 4 years later, survival rate is almost 20%. And also, reduction angioplasty is standard for functional MR, but it is associated with favorable RE result. But there are high reports that says high rate of MR recurrence and high rate of functional mitral stenosis during exercise. Then we decided to approach to the subvalvular apparatus. We called it a mitral complex reconstruction for functional mitral regurgitation. It's a mitral angioplasty plus papillary muscle approximation plus papillary muscle suspension. It's modifying. And according to that, our strategy, we defined our surgical strategy for ischemic MR. If the heart is not so big and LVDD under 65 millimeter and co-optum depth under 10 millimeter and interpapillary muscle distance under 30 millimeter, we just apply the angioplasty alone. And if the heart is not so big and under 65 millimeter and co-optum depth is over 10 millimeter or interpapillary muscle distance over 30 millimeter, we apply the angioplasty plus papillary muscle approximation. And if the heart is very big at over 65 millimeter of dimension, and this is over 10 millimeter and interpapillary muscle distance over 30 millimeter, we apply the papillary muscle approximation plus LV plasty. And just the result of the mortality, there is no difference between the three groups. It looks good, especially the cardiac-related mortality. That means our strategy is maybe the good, we think. Okay, the papillary muscle approximation in ischemic cardiomyopathy was done in 68 cases, and 73% was we performed the LV-plasty, and the LVDD was 68 millimeter, and the LV ejection fraction was 29%. 30-day mortality was 6%, and hospital mortality is 13%. Regarding the preoperative state, it looks not so bad. And freedom from all causes, survival after papillary muscle approximation in ICM, you can see the long-term result. 5 years survival rate is 56%. Comparing with medical treatment, it looks good, but not so satisfactory. And freedom from MR recurrence after papillary muscle approximation. Right side is the reported reduction angioplasty instance of MR recurrence. Comparing with the right side at the graph, the recurrence ratio is only 20% or so. But even the small number of the recurrence rate, 5 years later, maybe there's some kind of recurrence occurs, and 20%. And we applied this technique to the idiopathic dilated cardiomyopathy because in Japan, due to the shortage of the donor number, we applied this kind of operation. 81% had LV-plasty. LVDD was 75 millimeter, and the ejection fraction was 26%. 30-day mortality is 9%, and the hospital mortality was 8%. It was not good. Then we abandoned this technique right now. Freedom from all cold doses, 5-year survival rate is 38%. Still, it's not bad than medical treatment, but anyway, we abandoned this technique. Then we think about the backgrounds of this technique. Surgical ventricular reconstruction for non-ischemic DCM or severe ICM. In non-ischemic or ischemic cardiomyopathy with broad or severe kinesis, if ejection fraction cannot increase and stroke volume decrease after surgical ventricular reconstruction, it's not surprising theoretically. Then too much volume reduction is dangerous, as you know. And the other background is MV replacements versus replacements versus MV plasty. For treatment of severe ischemic mitral regurgitation, MV replacement, mitral regurgitation occurred more frequently in the repair group, resulting in more heart failure-related adverse events and cardiovascular admission. Then they concluded they recommend MV replacement rather than MV repair. But you can see the preoperative data, ESVI 61, and the ejection fraction is around 40. Not so bad, we suppose. And the other issue is, if you read this paper carefully, ESVI, left upper side, in repair group, the reverse remodeling seems tended to occur. And the replacement group, no, nothing happened. And ejection fraction, no change in repair group. The replacement group, ejection fraction decreased. Then the key point is ESVI with or without MR in repair group has reverse remodeling. But with MR, recurrent MR, there is no reverse remodeling. Then mitral repair may be better in case without MR recurrence. Then maybe the mitroplasty play a role, but the other issue is subvalvular apparatus. Recently, papillary mass approximation versus restrictive annuloplasty along for severe ischemic mitral regurgitation was reported. NAPI said after 4 years, after the operation, ejection fraction increase and reverse remodeling occurs after the operation. The effect is, we can see the effect just after the 4 years later. Anyway, maybe the subvalvular apparatus approach play a role. Then, as I said, if you do the MV replacement, no recurrence of MR was expected. Then, thinking about the mitral valve replacement, we should think about the caudal sparing mitral replacement. Really effective. It's controversial still now. This is a very old paper, but this paper, very good experiment, says that absence of caudal attachment after MVL in the normal canine heart does not adversely affect systolic LV function. They said so. Using the pre-recruitable stroke work, load-independent indicator. And also the other issue is which valve we should use, mechanical or biological valve. This paper is clearly demonstrated mechanical valve is better than biological valve in ischemic mitral regurgitation. during exercise, the better 6 minutes walk and effective orifice area and the systolic pressure, arterial pressure, pulmonary arterial pressure. Then we selected we plan to do the mitral valve replacement with subvalvular reconstruction. It works or not? We tried. We called it tugging approximation. Then maybe tugging effect in short axis occurs, and also the tugging effect in long axis occurs, we hope. And we position the papillary muscle head to the center of the LV. The reasons is I'm talking later. Mitral valve replacement may be no recurrence of MR. And if you don't do the LV incision, combination with regenerative therapy is possible, maybe, will be possible. This is the video, short video. Technique is very, very easy. You can see easily, you can cut the edge of the anterior annulus and fix to the commissure position, both of them. The excessive tissue is excised with a very big project and approximation to head of all the head of the papillary muscles with a pledget like this, and we plan to position the papillary muscle head to the center of the mitral valve, pulling up to the anterior direction, and perform the mitral valve replacement as usual. It's completely easy. Something like that. Then we did this operation in 17 dilated cardiomyopathy cases, non-candidate or refusal for transplantation, because in Japan, over 65 years old is non-candidate for transplantation. Then non-ischemic DCM was 8%, 8 patients, and the ICM 9% patient. And we performed this technique with system SVL, ventricular reconstruction, together in 3 cases. LVDD was around over 70 millimeter, and and systolic volume index is over 140, and ejection fractions around 21 or 22. And this is the result: no hospital deaths and 1 late sudden death in his house. And the LVDD decreased, and ICM. In ICM, the same thing happened, but not so statistically different. But the ejection fraction improved, and for the stroke volume index increased in DCM cases to the normal level, and in ICM maintained. And BNP decreased rapidly during his hospitalization. This is the case of one case. In PMT DCM, non-ischemic DCM cases, ejection fraction was 15%, DD 87 millimeter, something like that. BNP 1,044. He's not a candidate in Japan for transplantation. 1.5 year post-operatively, ejection fraction improved to 46%. DD decreased to 57 millimeter. And she's recovered very, very well. And also, this is the other case, ejection fraction, pre-operative ejection fraction 12%, DD 58 millimeter, not so big heart. But he's a catecholamine dependent, and he couldn't discharge from the hospital. And 2 years later, she recovered very, very well and came back to her job. The ejection fraction recovered to 54% DD, 45 millimeter. BNP decreased from 800 to 80. It's surprising for us. Then we are continuing this technique. We think about why it works so well. There is the same, almost the same technique reported in just one paper. They applied the cross-papillopexy in 15 patients, no hospital mortality, but you can see we can see ejection fraction of these cases around 62%. Then this is not very, very bad cases. The other issue is vector flow mapping. We analyzed the vector flow mapping in these operations, after operations. Ejection vector formation time is decreased. And recently we submitted this report, energy loss evaluated by vector flow mapping after papillary muscle tugging approximation with mitral valve replacement. Energy loss was calculated, the left-sided, very, very complicated formula, and the energy loss index was defined by energy loss by LV forward stroke volume. Then we concluded, comparing with conventional mitral valve replacement, the energy loss is very, very small in tugging approximation. That may play a role maybe in case of very, very severe heart failure. Then conclusion, MV replacement plus papillary muscle tugging approximation is under trial for the idiopathic or severe ischemic cardiomyopathy patients who are not candidate to a refusal of blood or heart transplantation. The short-term results were satisfactory with excellent survival rate and the quality of life. The randomized study, including long-term follow-up comparing corridor-sparing MV replacement alone and MV replacement with papillary muscle tugging approximation, and also mitral valvoplasty are mandatory. Thank you.
Thank you very much. I didn't understand, in the patient with the ischemic cardiomyopathy, did you do bypass surgery too?
Yeah.
In all cases, or?
Not all cases. Almost in this cohort, maybe 50% of the cases had a cabbage because of the previous PCI or something. Then we don't trust in the cabbage effect after the operation.
And what is your pathophysiologic explanation for the improvement in the ejection fraction?
That's why I termed this technique tagging. It's something like helping to moving up with some arm or something. Can you understand? If you pull the other side with some kind of rope, something like that, I'm a papillary muscle, and we can move easily with some kind of a rope to the other side. That make a sense maybe. I don't know exactly about that. We are trying to find what beneficial effect of real beneficial effect of papillary muscle tugging approximation. We are trying to do that.
The same result if you repair this valve? I mean, do you have the same result if you put only ring? I mean, it's difficult to, you see what I mean? It It's not the problem of the prosthesis.
Ah,
I mean, we have the prosthesis and the papillary muscle. Now, if you don't touch valve,
yeah, you're right,
you
maybe.
leave. Maybe you will.
And then I said, and even with the papillary muscle approximation with mitral valvoplasty, the recurrence rate is around 20%.
Yes.
Then, if 44 years later, after the operation, first operation, the patient is very, very bad state, then we can't do anything. That's why we have several, not just several, over 10 patients who come back to the hospital with cardiac heart failure. Yes. Then we can't do anything, but with the recurrent MR, but we can't touch the patient. That's why we are trying to do such a kind of operation.
Yeah, I understand, but I mean, my question is, if it is effect of the papillary muscle tucking, you should have the same result if it is a replacement or repair.
Yeah, and the other issue is if you approximate just the head of the papillary muscle, we report that it doesn't work well. We call it partial papillary muscle approximation. And the complete approximation is from the base of the papillary muscle to the head of the papillary muscle. It works very, very well. That's why we reported that. Then we don't trust the partial papillary muscle approximation. Then that's why we are applying mitral valve replacement rather than in that very, very severe case only. If the patient is not so severe, we are trying to do the way you mentioned.
Any other questions? Okay, then thank you very much. And I think we can conclude the session for today. Wish you a nice evening. See you tomorrow.